Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 414 of our pharmacotherapy series, which majors in lower gastrointestinal disorders. This clinical case involves patient TCJ from part 413 of this pharmacotherapy series. 6 weeks after starting to taper TCJ's prednisone dosage, currently 10 mg per day, and the initiation of azathioprine, he returns to the clinic for routine laboratory monitoring. His WBC count is 1,800 per microliter, with an absolute neutrophil count of 1,100 per microliter. He is afebrile and without complaint. His physical examination is negative for any sign of infection. So my first question to you reads: why is TCJ experiencing leukopenia? What is the treatment for this side effect? Let's now look at 6-mercaptopurine and azathioprine monitoring. Azathioprine is a prodrug that is converted to the active moiety, 6-mercaptopurine, in the liver. 6-mercaptopurine is then metabolized by xanthine oxidase, hypoxanthine guanine phosphoribosyl transferase, or thiopurine S-methyltransferase, abbreviated as TPMT. Genetic polymorphism determines the extent of thiopurine S-methyltransferase activity. In approximately 90% of whites, thiopurine S-methyltransferase activity is considered high, but the remainder of the population has either intermediate or low thiopurine S-methyltransferase activity. These patients are predisposed to 6-mercaptopurine or azathioprine myelosuppression because diminished thiopurine S-methyltransferase activity leads to the metabolism of these compounds being shunted to the other enzymatic pathways. Accumulation of the 6-thioguanine byproducts is correlated with leukopenia. Pharmacogenomic testing to assess thiopurine S-methyltransferase activity has been developed and found to be effective in guiding therapy with azathioprine or 6-mercaptopurine while minimizing the incidence of bone marrow suppression. The Crohn's disease guidelines note that no randomized controlled trials have compared pharmacogenomic-guided dosing to usual care dosing in patients receiving azathioprine or 6-mercaptopurine. However, the U.S. Food and Drug Administration recommends such testing before initiating these medications. Additionally, several retrospective studies have assessed the clinical utility of measuring azathioprine and 6-mercaptopurine metabolites such as 6-thioguanine and 6-methylmercaptopurine. Although some experts have used these data to suggest a therapeutic level for these metabolites, e.g., 6-thioguanine levels of 250 to 400 picomoles per 8 × 10⁸ red blood cells have been considered optimal. the Crohn's disease guidelines do not recommend their routine use. The optimal role for these tests remains to be fully determined, and data in this area are rapidly evolving. In patients who have experienced neutropenia from azathioprine therapy, as TCJ has, the primary treatment is to discontinue azathioprine. In most cases, the WBC count will normalize over the course of several days to weeks. In extreme cases, the use of granulocyte colony stimulating factor may be considered. TCJ should be monitored for signs and symptoms of infection, and the azathioprine should be withheld. Frequent, conceivably daily, WBC determinations should be made until the count is greater than 3000 per microliter. TCJ's leukocyte count returned to normal after 2 weeks. Unfortunately, he experienced a flare of his Crohn's disease symptoms, specifically, an increase in diarrhea and abdominal pain that TCJ has noted during the past 5 days. So my question to you reads: what other agents should be considered to maintain remission in TCJ? A number of other immunosuppressive drugs have been examined in Crohn's disease. Methotrexate produces and maintains remission in patients with refractory disease. Clinical improvement or reduction in corticosteroid dosages have been observed with 15 mg per week oral methotrexate or 25 mg per week of intramuscular or subcutaneous methotrexate in roughly 40% of patients who had active bowel disease. In clinical studies, gastrointestinal toxicity was the most common reason for discontinuing treatment, but neutropenia and liver enzyme elevations were also reported. Current guidelines recommend reserving methotrexate for patients who have failed or are intolerant of 6-mercaptopurine or azathioprine. Some experts consider methotrexate to be inferior to 6-mercaptopurine or azathioprine in Crohn's disease, but no comparison studies have been published to date. Given an apparent therapeutic failure with azathioprine, a reasonable approach would be a short course of corticosteroids, prednisone 40 mg daily with a taper for 6 to 8 weeks, and methotrexate 25 mg weekly. Folic acid 1 mg daily should be initiated in patients started with the methotrexate. Methotrexate use may result in a depletion of folate stores because of dihydrofolate reductase inhibition. Alternatively, biologic therapy could also be considered. TCJ has developed an enterocutaneous fistula with his latest disease exacerbation, and nothing is helping him achieve remission. So my question to you reads: what alternatives are appropriate for TCJ? Recent guidelines recommend that antibiotics have little role in the maintenance of remission in Crohn's disease, but they may be helpful in fistulizing disease or in patients with abscesses. Taste disturbances and peripheral neuropathy are the most commonly reported adverse effects associated with metronidazole treatment. Let's now look at infliximab. Infliximab is now firmly established as an important therapy in the treatment of Crohn's disease, especially fistulizing disease. However, A number of concerns regarding this agent must be discussed with the patient before initiation of therapy. It is an expensive therapy, that is approximately $15,000 per year, although it may be cost-effective in Crohn's disease. Fistulizing disease seems to respond particularly well to infliximab, and its use may avert the need for surgery. Acute and delayed hypersensitivity reactions can occur and are occasionally life-threatening. Some clinicians pre-medicate patients with a combination of diphenhydramine, acetaminophen, or corticosteroids before an infusion. However, the most effective strategy to avoid a serious reaction is to regularly monitor vital signs during infliximab infusion and slow the rate or stop the infusion if any symptoms develop. The majority of reactions consist of headache, flushing, itching, and dizziness, with anaphylactic reactions rarely occurring. Also of concern is the development of human antichimeric antibodies in some patients receiving infliximab, which may lead to either loss of response or immunologic adverse reactions. Infliximab should be avoided in patients who have a serious active infection. Because of reports that infliximab treatment may reactivate tuberculosis, all patients considered for treatment must receive a tuberculin skin test to rule out the disease. If this test is negative and because TCJ does not appear to have any other contraindications, he would seem to be an appropriate candidate for infliximab. If latent tuberculosis is found, antitubercular treatment must be initiated before infliximab can be considered, since patients with treated latent tuberculosis still have an increased risk of active disease. In addition, screening for hepatitis B, and probably hepatitis C, is reasonable owing to the number of cases describing reactivation of these viral infections. Current data concerning a link between TNF-alpha blockers use and malignancy are conflicting. To date, the balance of data suggests a small but real risk of developing lymphoma in Crohn's disease patients using TNF-alpha blockers, but despite this, its use is associated with an increase in quality-adjusted years of life. Another problem commonly faced by clinicians and patients is loss of effectiveness in patients receiving TNF-alpha blockers. This may occur months or years after initiation of therapy. Common strategies to regain response may include increasing the dose of infliximab to 10 mg per kilogram per dose or switching to another TNF-alpha blocker. The success of these strategies is variable, and often comes with significantly increased treatment costs. A recent paper has shed light on the possible causes of this loss of efficacy. In 155 patients receiving infliximab, who had declining response to the drug, both trough serum infliximab levels and human anticlonal antibodies, abbreviated as HACA, were measured. The authors found that in patients with subtherapeutic trough infliximab levels, increasing the dose of the drug was a successful strategy to regain response, whereas those patients who were human anticlonal antibodies positive benefited more from changing to another TNF-alpha blocker. Such laboratory markers may have the potential to be routinely used to assess the effectiveness of infliximab, but more data on this issue are needed to make such a recommendation. TCJ was initiated on infliximab 400 mg IV every 8 weeks, and it was successful at keeping him symptom-free. However, after 2 years of remission, TCJ is hospitalized for an acute exacerbation of right lower quadrant pain associated with abdominal distension, lack of bowel movements, and vomiting during the past 24 hours. Radiographic studies indicate partial small bowel obstruction at the terminal ileum. So my question to you reads: is surgery indicated at this time? Because medical therapy of Crohn's disease is often inadequate, 78% of patients with this disease will require surgery within 20 years of symptom onset. In contrast to ulcerative colitis, surgical removal of the involved bowel in Crohn's disease is not a definitive form of therapy. Crohn's disease can recur even after extensive resections. Various investigations have determined that cumulative recurrence rates after surgery for this disease are as high as 80%, depending on the surgical procedure and disease location. Therefore, multiple operations and their attendant risks are often necessary during the life of the Crohn's disease patient. Depending on the amount and site of the bowel removed during surgery, specific malabsorption syndromes can occur, e.g., vitamin B12 malabsorption with removal of the terminal ileum. If an ileostomy is part of the surgical procedure, the patient will have to undergo significant psychological adjustments. Therefore, surgery is indicated only for specific complications that are unresponsive to medical therapy, and it should be avoided if possible. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 415.